Good morning and welcome. My name is Damon Bennett and I am the MRI Clinical Specialist for Australia and New Zealand and presenter and host for this third presentation in the 2020 webinar series, proudly brought to you by ANZ GE Healthcare. Now today I'm going to be discussing image optimization in MSK. Now this is really important topic. So I'm going to be focusing on the correct ETL selection and why that's important in MSK, the application or use of fast recovery pulses, the selection of the correct bandwidth in MSK imaging and its critical importance in image quality. I'm going to be talking about NEX or multiple averaging in MSK, and I'm going to round off with a discussion on phase encoding, slice thickness and pixel size. Now I really hope you enjoyed today's presentation, but please watch out for the invitations that are going to be sent out shortly for our next webinar, which will be presented by Dr. Colin Chong and is going to be on the more advanced application of MRI in MSK imaging. Just a bit of housekeeping before we start. As we go through the webinar, if you're watching live and have questions, please send your questions via the little link at the bottom of your screen. We will try to answer as many questions as we can at the end of the presentation, but we might not get to them all depending on how many we receive. At the end of the presentation, we would also appreciate it if you could complete the feedback form, as this helps us make future presentations better for you. But if you can also download your CPD certificate prior to providing the feedback to ensure smooth access to your claim points. Now, depending on your firewall settings and the browser used, you may not be able to claim your CPD immediately. If that happens, don't worry, you're going to be sent a follow-up email thanking you for attending, at which point you will be able to claim your CPD points then. If you're having any technical difficulties during the presentation, the On24 team will be able to help you via the troubleshooting box at the bottom of the screen. Lastly, if you're watching this on demand, make sure that your screensaver is not activated, as the system may think you're no longer watching and it won't count toward time towards your CPD certificate. Again, I hope you enjoy the presentation and thank you for joining me. So let's go into our first discussion point, the selection of ETL. These days, most sites use fast spin echo imaging. Why do we use it? Well, simply it just comes down to time. The reason it is, fast spin echo uses an echo train length, which is an important parameter as it's inversely proportional to the acquisition time. For example, if you were running a 4-minute spin echo sequence and you increased it to have an ETL of 4, you've now got a scan time of 1 minute. Now, when we change from a spin echo to a fast spin echo though, the TE that we select is actually replaced by an effective TE. And this is the point in which the central lines of K-space are filled and multiple signals are collected. But the incorrect selection of an ETL is actually detrimental to image quality, especially in musculoskeletal imaging. So let's go into our first clinical example of this. So here we have a standard PD sagittal knee. It's a 14 centimetre field of view. It has reasonably high res of 320 by 256 and 1 NEX. So there's a few things I'd like to note about this sequence. Firstly, the scan time is about 2 minutes and 36 seconds. We're using a TR of 2,595 and an effective T of 27. The other factor to note with this sequence is as an ETL of 12. Now, if we look at that image, it's a fairly acceptable image and we'd be happy with that every day. But don't forget, the first thing that happens when we push this to a radiologist is they zoom these images up to have a look at them more closely. The last important factors to note are the echo spacing, which is 7, which is really nice and tight for MSK imaging, and the minimum and maximum TEs, which are 7 milliseconds and 84 milliseconds respectively. So now we're going to have a look at our second example. So in this sequence, again, you can see that everything has been kept constant. It's a 14 centimetre field of view. It has the same number and thickness of slices, same resolution, same NICs. You will notice that the TR is a little bit longer. This is 3,927. The scan time is quite comparable at 2 minutes and 29 seconds. It's just marginally faster. And again, the same TE. What we will note is different in this sequence. We have an ETL of 9. Now again, as soon as we push this to our radiologist, they zoom them up. The other interesting thing to note is we've kept the same TE, the ETL has been reduced to 9, the echo spacing has remained the same so that we can directly compare the two images, but we will notice with the reduced ETL length that our minimum and maximum TEs have changed from 7 and 84 to 7 and 62 milliseconds. So let's just take a moment again just to have a look at these two images side by side and compare the acquisition with an ETL of 12 and an ETL of 9. Again, these both look very presentable, very nice images on your monitor as you're looking at them as a tech. But again, remember the first thing the radiologist is going to do is zoom these images up. And if we have a look now and compare them, now we're starting to see some differences. We can actually see that the cortical margin on both the anterior aspect of the hyaline cartilage and at the posterior aspect of the cortical bone is different between the scan acquired with an ETL of 12 and an ETL of 9. So why does this occur? Well, as we discussed earlier, fast spin echo sequences don't have a TE, they have an effective TE, which is at the center of the ETL chain. Increasing the ETL can speed up the scan, but it doesn't change the effective TE. What it will do though is it can induce a loss of signal to noise and image blurring if not used in conjunction with the correct TE. Longer ETLs result in more T2 weighting because late echoes contribute to the overall signal, and longer ETLs are associated with a decrease in overall signal to noise because the later echoes are also weaker due to the T2 decay effects. So let's dig a little bit deeper into the root cause. So if we look at the scan that was acquired with an ETL of 12, we noted that the minimum TE was 7 milliseconds and the maximum TE was 84 milliseconds. So the mid ETL point on the echo train length is going to be 84 minus 7, which is 77.1 milliseconds. The TE should be half of your ETL, so therefore it should be 38 milliseconds, but we're actually forcing the system to acquire a TE of 27 milliseconds. So how do we correct this? Let's adjust our ETL. So if we look at the second sequence, we can see that we had a minimum TE of 7 milliseconds, a maximum TE of 62 milliseconds. So the mid ETL point is going to be 62 minus 7, which is 55 milliseconds. The TE should be set to half of your ETL, which is 27. The prescribed 27 milliseconds is in the mid ETL. And again, if we look at these images, the image on the left with the ETL of 12 is not bad. Like, it's reasonably good and you'd be happy if you got that on a day-to-day basis. But remember, we went from a 2 minute and 36 seconds down to 2 minute 29. We've actually saved a little bit of scan time, not that that was the objective, but in saving that small amount of scan time, we've actually increased the spatial resolution of the image at no cost. So can the ETL have an effect on image quality? Yes, it can. As we saw in the example, as the ETL increases, PD and T1 contrast decreases. T2 contrast increases because you're capturing information from later in the echo train length. The number of slices will decrease as the ETL increases. You can get edge blurring increases, and scan time will decrease a little bit as you increase your ETL. Using the correct ETL though will reduce some of that image blurring. It will give the appearance of higher resolution without a time penalty, and it's actually going to reduce the SAR that you're dumping into the patient because we're sending in less refocusing pulses, so therefore less SAR to the patient. So what are the recommendations? So if you're doing a T1 weighted sequence, you should be using an ETL of about 2 to 4. If you're doing a PD, whether it's FAT-SAT or non-FAT-SAT, you should be looking at ETL lengths of 8 through to 12, depending on the TE that you're after. And on T2 weighted sequences, again, whether they're FAT-SAT or non-FAT-SAT, you should be looking at ETL lengths around the 16 to the 24. Another interesting point you may have noted is when we're running the scan with an ETL of 12, it was divided into 2 packages, which took our TR well below 3,000 to 2,595. in difference to the scan required with an ETL of 9, which was only one package and had a TR of just under 4,000. Now the advantage of that is we are getting full relaxation of all the water molecules in the transverse plane back up into longitudinal for the next excitation without the need for a crusher pulse or a fast recovery pulse. So this leads into a discussion about fast recovery. So what is fast recovery? Fast recovery is a user-defined option that can be applied to ensure that we collect all of the available water molecules without the need for long TR times. So don't forget, if you're using a TR under about 3,500 milliseconds, there might not be sufficient time for all of the available water molecules to relax back to B0 ready for the next excitation. So how does fast recovery work? It employs a reverse flip angle excitation pulse at the end of the echo train that removes all residual transverse magnetization, and this permits all tissues to be available for excitation at the beginning of the next TR. We've got to remember that fluid has long T1 and T2 relaxation times, so this fast recovery pulse forces all of the water molecules back into the longitudinal axis, which means that they will retain their hyperintense signal even when using shorter TR times. Why is this important? Fluid is often an indicator of pathology, especially in musculoskeletal imaging. So fast recovery is a very useful tool that can be used to ensure that we collect all of the available signals and show all the pathologies that we needed to whilst using lower TRs. So this slide is a great example of the application of a fast recovery pulse and its ability to reduce scan time whilst maintaining a hypersignal intensity within the free fluid, in this case in a lumbosagittal spine examination. So if we look at the image on the left, we can see that we have a TR of 3,625 milliseconds and a scan time of 3.5 minutes. All other parameters remain the same, including the ETL of 24. If we look at the image on the right, we can see that with the application of a fast recovery pulse, we're able to reduce our TR down below the 3,500 millisecond threshold. And in this particular case, the TR is down to 2,976, giving us a scan time of 2 minutes and 53 seconds, or a saving of over 30 seconds, whilst retaining the hypersignal intensity within the water. So why is this important to understand in musculoskeletal imaging? If we remember back to the previous example, we were running an ETL of 12, which divided our acquisitions into 2, which meant we were running a TR of about 2,900 milliseconds, which meant we had to have a fast recovery pulse on. However, when we changed our ETL of 9, it went back to 1 acquisition and our TR went up to 3,900 odd, which gave us a scan time of 2.5 minutes. But because we're above that threshold of 3,500 milliseconds, we could, if we wanted to, we could take fast recovery off. Our TR drops down to still above the threshold. It's not a massive time saving, it's about 15 seconds, but it's not always that small. Sometimes you can save yourself 30 seconds, sometimes you can save greater than that, sometimes it's only the 15 seconds. But if you can save 15 to 30 seconds per acquisition, so long as you ensure that your TR stays above that 3,500 millisecond mark, you can take the fast recovery pulse off and save yourself some scan time. Now, just before I get into the next topic, please remember that if you do remove fast recovery from any of your sequences, you must monitor your TR to ensure it does not drop below 3,500 milliseconds, or you will negatively affect your image quality. Now, before I get into using bandwidth to improve our image quality, I need to get a bit of an understanding and do a revision on how bandwidth works for and against us and its relationship with chemical shift. Quick bit of revision here. Remember that the receiver bandwidth is measured as the range of frequencies in kilohertz plus and minus either side of the center frequency, and it is the rate at which the echo is sampled by the readout gradient. By changing the value of the bandwidth, you can control how many frequencies are going to be read in each echo. Don't forget that noise is a constant in the background. So our bandwidth is going to determine how much signal from the center of the echo is collected relative to how much noise in the background. As the window narrows, less noise is detected, as we are just collecting within the center of the echo. As the window widens, we're now broadening outside of the signal within the FID. We're collecting more background noise, and this will have an effect on our chemical shift. So we need to remember that fat molecules experience a slightly weaker local magnetic field and will resonate at a slightly lower frequency than a nearby water molecule. And in most anatomical regions, we have fat and water in close proximity. Now, the differences in frequencies is extremely small. It's only about 3.4 parts per million. At 1.5 Tesla, this corresponds to a frequency difference of about 215 Hertz. At 3T, the frequency difference is doubled to about 430 Hertz. And this difference in frequency is called chemical shift. Now, because MRI uses resonant frequencies for spatial encoding of the information, this frequency difference causes a small shift between the water and the fat position in the frequency direction of the MR image, and this is called chemical shift. So chemical shift is defined as the displacement of the water signal with respect to the fat signal in the frequency direction of the image and can be expressed as a number of pixels. So how does chemical shift present itself? This misregistration or mismapping of the water and fat pixels results in an artifactual white or dark bands or blurring of the boundaries on either side of an anatomical object in the frequency encode direction. Now, the artifact is most commonly seen around water-containing structures like the liver, kidneys, optic nerves, thecal sac, etc., that are surrounded by fat. So if we look at this image down on the bottom left, we can see in this axial abdomen, we've got dark and light bands on either side of the kidneys, which is a fluid-filled structure surrounded by abdominal fat. Now, depending on the anatomy that you're looking at, sometimes there can be a certain amount of chemical shift that is completely acceptable. And this image on the left has about approximately 3 pixel chemical shift. But that same image, if we take it in its entirety, is completely fine, as we can still see the pancreatic duct in this particular case. So in abdomen imaging, a 3 pixels might be fine, but in MSK, it's not going to be. Any chemical shift within an image is directly proportional to the bandwidth selected. Now, don't forget, bandwidth defines the range of frequencies either side of the center frequency. So if you were to select a bandwidth of 16, you're actually collecting 16 either side of the center frequency, or a total of 32 kilohertz. Regardless of what you select, you're actually acquiring or collecting information twice the bandwidth prescribed. Now, we need to remember that signal-to-noise improvement is the inverse of the square root of the old bandwidth to the new bandwidth. So using the example from the last slide, if we had a bandwidth set of 32 kilohertz and we took that down to 16 kilohertz, that is the same as the square root of 2, which is approximately a 41% increase in signal-to-noise. But as we're all very familiar with MRI, nothing comes for free. So if we look at the use of lower or narrower bandwidths, we can see on the image that we're collecting most of our data in the middle of the FID and limiting the amount of noise, which means we have images with higher SNR and we have the ability to use smaller fields of view. The downside of this is we have increased chemical shift, longer minimum TE, longer echo spacings, which will also increase our blurring, and we're more susceptible to artifacts. Using higher or broader bandwidths mean we're less susceptible to chemical shift artifact. We have shorter minimum TEs available to us, shorter ETLs, and we decrease our susceptibility of metallic artifacts. Unfortunately, with the higher bandwidth though, we have lower signal-to-noise because we're collecting more of the background noise on either side of our FID, and we are limited to larger minimum fields of view. So let's have a look at the effect of chemical shift and bandwidth selection in MSK imaging. Here we have an oblique coronal PD shoulder with defined parameters set with a chemical shift of 1 pixel. In this image, we can see we've got very clear definition of the cortical bone on the humeral head, but we can see that the image is also a little bit noisy. Our hyaline cartilage is struggling a little bit, and we're not picking up the fluid signal in the center of the joint clearly. If we then go to the exact same patient, same parameters, same everything, the only thing that is altered is we've changed our bandwidth to have a chemical shift of 1.5 pixels. Now, if we look at this image, we can see that we've still got nice, clear definition of the cortical bone and the humeral head, but we've now got a lot more signal to noise, and we've got beautiful detail of the hyaline cartilage and the fluid within the joint. Same patient, same parameters. Again, the only thing that's been altered is our bandwidth to now have a chemical shift of 2 pixels. And it's very obvious that we can see we've lost the dense cortical bone signal, and we've now got blurring of the hyaline cartilage over the top of the cortical bone, which is making this image suboptimal. So based on our last experiment, we can see that for this particular instance of this shoulder in the coronal oblique PD, that it appears that a 1.5 pixel gives us the best balance of signal to noise, limited chemical shift, and high image quality. So despite a small amount of respiratory motion, it's very obvious that there is a significant difference in image quality on this same patient using the same parameters with a chemical shift of 1.8 versus a chemical shift of 2.2. So we can actually roll out recommendations for MSK imaging. So for non-FAT-SAT imaging, the suggested chemical shift in pixels is around the 1.5 to the 2 or even slightly higher, depending on the anatomy that you're looking at. And for fat-saturated images, we can have the pixel shift a bit higher because we don't have that same interaction between the fat and the water molecules, and we can use this to get back a little bit more signal to noise. So let's say that we've decided we like a 1.5 chemical shift as a nice balance between signal to noise and acceptable image quality. Now there's a complicated way to calculate this, or there's a very simple way that GE does it for you that I'll show you in a couple of slides. But the longer way to work this out, for this example, if you have a receiver bandwidth of say 50 kilohertz, now remember this is 50 kilohertz either side of the center frequency, and the frequency matrix is 320, then the bandwidth per pixel is calculated as 100,000 divided by 320, which comes to 312 hertz per pixel. Now, since the water-fat frequency difference at 3T is about 430 hertz, as we mentioned before, or 215 at 1.5, then the chemical shift artifact will be 430 hertz divided by 312 hertz per pixel, which works out to be approximately 1.4 pixels. A simpler mathematical equation to do this for you is to use a factor. So in this case for 3T, it's 0.22 times the frequency matrix divided by the bandwidth in kilohertz equals the chemical shift in pixels, or again for 1.5, the factor you use is 0.11. So to give a nice working example of this, on a 3T system, if we've got 0.22 times the frequency matrix, which in this case is 320, divided by the bandwidth, which is 50, we have a 1.4 chemical shift in pixels, or again, we substitute 0.11 if we're on a 1.5T system. One of the nice things about mathematics is we have the ability to flip the equation around to suit our needs. So what if we had a set frequency matrix that we were after, but we were trying to determine what bandwidth we wanted to select a certain chemical shift in pixels? In this particular case, for a 3T, again, we just swap the equation around to have the factor of 0.22 times our frequency matrix, and then divided by the chemical shift in pixels that we're after, and this equates to 37.5 in this equation that you can then type into your selection, or again 0.11 for 1.5. So as mentioned previously, if you're on a GE platform on software levels 26 or greater, the system's smart enough to do all the hard work for you. The system will look at the frequency matrix, it'll look at the bandwidth you've selected, and it will automatically calculate the bandwidth per pixel. The beauty of this, if you're on a 3T system and you've selected that you would like a chemical shift of approximately 1.5 pixels, you simply set your bandwidth per pixel at around the 310 to 320 mark. If you're doing fat-sat imaging, where you can allow a little bit more pixel shift in without affecting the image quality and gain a little bit more signal to noise, you can drop that bandwidth per pixel down to approximately 190. The same thing on a 1.5. You're looking at a 145 bandwidth per pixel for non-FATSAT imaging and around the 100 bandwidth per pixel for FATSAT imaging. So these next few slides are a really good example of how changes to the bandwidth relative to the frequency matrix can maintain a bandwidth per pixel to give you the desired image quality. So on the left-hand side with the green circle, we have a 1.5T system. To achieve a 1.5 pixel chemical shift, we're after a bandwidth per pixel around the 140 mark. So having a frequency matrix of 512, a bandwidth of 35, gives us the desired bandwidth per pixel. On the right, our 3T system for a frequency matrix of 512, a bandwidth of 83.3, gives us a bandwidth per pixel around the 320 mark, giving us the desired pixel shift that we wanted. As we can see on both 1.5 and 3T systems, as we reduce our frequency matrix, a corresponding drop of our bandwidth selection can maintain the same bandwidth per pixel and keep the same image quality. Again, as we go even lower, we can maintain that same bandwidth per pixel, regardless of the frequency matrix that we select. With FATSAT imaging in MSK, we have a bit more latitude. Due to the negation of the FAT signal as part of the fat saturation process, this reduces some of the effects of chemical shift. This allows us to use narrower or lower bandwidths and therefore lower bandwidth per pixel ratings. So if we were happy with a 2 to 2.5 chemical shift in pixels, our bandwidth per pixel on a 1.5T system is around the 100 and on a 3T system is around the 190. And as before, this continues down to low frequency matrix, but maintaining that same bandwidth per pixel. For those of us who don't yet have the bandwidth per pixel software, a simple table can be calculated for either a 1.5 or a 3T system, which will give you an easy cross correlation between the matrix, frequency matrix that you're after and the desired bandwidth to achieve a chemical shift of say 1.5 or 1.8 or even 2 pixels for both non-FATSAT and FATSAT imaging. So the selection of your bandwidth relative to your frequency matrix is critically important in maintaining a balance between image quality, signal to noise, and artifact. For most musculoskeletal imaging, a chemical shift of 1.5 to 2.5 pixels is recommended, but that varies depending on the anatomy under investigation and how small your pixel size is. So don't forget, as your bandwidth decreases, your signal to noise goes up, you'll have smaller fields of view available, but your ETL increases, your minimum TE increases, your chemical shift increases, and your artifacts increase. As your bandwidth goes up, your signal to noise goes down, but your ETL reduces, your minimum TE reduces, and your chemical shift and artifacts will reduce as well. So as I've just mentioned, pixel size is also very important in MSK imaging. In musculoskeletal imaging, it is optimal to have a pixel size below 0.5 of a millimeter squared. On most GE platforms, that data is easily displayed on the main page. However, if you need to calculate it, it's a simple calculation of the field of view divided by the frequency matrix and the field of view divided by the phase matrix. Now, in proton density imaging, as we're collecting the signal from both water and fat molecules, these sequences have inherently high signal to noise, so we're able to achieve smaller and lower pixel size than we would on other sequences. In this example, we are 0.37 by 0.44. In T1 weighting, there's not as much signal to noise as proton density, so there's been a slight drop in our frequency matrix to buy back a little bit of signal to noise, but still maintaining a 0.41 by 0.44 pixel size. So when we start looking at fat-saturated sequences for MSK, again, we need to try and keep our pixel size down close to that 0.5 millimeter squared. So there's been a slight reduction in both the frequency and the phase matrix, keeping a pixel size of 0.46 by 0.53. So whilst we want to keep all MSK imaging below the 0.5 millimeter squared pixel rule, the only exception is going to be STIR due to the inherent low signal to noise, where it's acceptable to go to a pixel size of 1 millimeter cubed. In this example, we've used a rectangular pixel where we have a 0.5 by a 0.83 millimeter pixel. I'm just going to finish off now with three last topics to do with NICs, phase encode direction and signal to noise. Now the subject of NICs and musculoskeletal imaging is quite interesting. Now NICs is the number of times the phase encoding steps are repeated in a given acquisition. I'm sure we're all aware increasing the NICs from say 2 to 4 is going to give you an approximate 40% increase in signal to noise, but also unfortunately a doubling of the scan time. The other interesting thing to note with NICs is the multiple averaging of small patient motion due to breathing or peristalsis can actually remove some of the fine detail within your image. So taking your NICs to a high level can actually work against you. You're better off if you're chasing signal to noise to look at reducing acceleration factors or increasing the phase field of view. The selection of your phase encoding is also really important to prevent pulsatile effect from affecting your image quality. This pulsatile artifact from the popliteal artery going across the knee anatomy is due to an AP phase encode selection and is easily avoidable. Simply swap your phase encode to have it in the head foot or SI direction. Make sure that you have some no phase wrap on to prevent wrap coming back into your image, and you completely negate that pulsatile artifact. So I'm going to finish today talking about simple ways to improve your image quality purely by analysing the signal to noise available to you in your current imaging. Sometimes small changes to 1 or 2 parameters can have significant effects in improving image quality. If we look at this PD coronal ankle acquired at 3 millimeters thick, we can see that there's quite a lot of signal to noise still within that image. No other parameters were changed, simply reducing the slice thickness down to 2.5 millimeters thick without changing anything else has resulted in a significant improvement in image quality, including the beautiful trabecular detail as shown here. Another example of using signal to noise to your advantage, this sagittal PD ankle acquired at 2.7 millimeters thick, when reduced down to 2.3 millimeters thick, actually shows more pathological detail, thus making it easier for your radiologist to provide an accurate diagnosis. So that concludes today's presentation. Now, just before we get into the questions, if you or your staff need access to information or training materials and earn CPD points in the process, there is a great resource called GE Cares. Once you're registered with GE Cares, you're going to have access to webinar replays, quick reference guides, and e-learning modules. Now, if you're after guidelines on the GE recommendations for cleaning your equipment, the following website may be of assistance. So if you are in Australia or New Zealand and you want to register for GE Cares, please just go to the website www.gecares.com and click on Join the Community. And then you simply enter GIB_S_AU_ and then your equipment number, or if you're from New Zealand, just swap out the AU for the NZ. Then you simply enter your email address below that. So again, I'd like to thank you for giving up your time today. I hope you enjoyed the presentation, and we will now take any questions. Thank you again.